So let's finish talking about the respiratory system. I'm going to keep this short and sweet. We've talked up to this point pretty in depth about the anatomy of the respiratory system. We've talked about it's broken up into an upper respiratory tract and a lower respiratory tract. Upper respiratory tract would be your nasal cavity, your your pharynx and your larynx. And then secondarily, your lower respiratory tract would start with your trachea, your bronchi, and then your lungs themselves, or really you could say the alveoli at the microscopic level, at the tail end of all those bronchioles, the smallest bronchi at the very small end inside your lungs is just filled with millions upon millions of alveoli, the exchange area where the blood vessels meet the airspace and oxygen comes in and CO2 goes out at that point. Okay. So talking about how pulmonary ventilation is talking about just in general, like how do we breathe? What are we doing? That sort of stuff. Okay. And so big thing with pulmonary ventilation in your book, I don't have page numbers in front of me. I'm looking at kind of the ebook and stuff, but respiratory muscles is kind of where I'm talking at and how that, so inspiration, expiration, all that is kind of depending on, again, your is all depending again on your muscles moving. So big guy, of course, is your diaphragm. That's the most important muscle for breathing. When I breathe in, when I inspire, my diaphragm pulls down. And then we have what's called our intercostal muscles. So there's an external and internal intercostal muscles. I'm not too concerned about that. You should kind of have an idea. You need to know the name. It's intercostal muscles. These are the muscles that run in between the costal cartilage of your ribs, run between your ribs. And so when I breathe in, inspiration, when I breathe in, my diaphragm pushes down, right? And my intercostal muscles pull up and out my ribs to kind of expand my lungs, make my thoracic cavity, make it as chest cavity as big as it can be. That's breathing in. And then all those muscles relaxing goes back to a resting state. That's expiration. And that's why inspiration takes energy, is an active process of the muscle moving, and expiration is a passive process moving out. Okay. And so make sure that's understood. And again, what pulmonary ventilation is, how we breathe in and out is based on pressure. Okay. It's based on pressure, atmospheric pressure. So the pressure in the air around us and the pressure inside our lungs, along with this muscle movement that's dependent on our respiratory center and our nervous system, our medulla oblongata, and depending on just other nervous system impulses, depending on what's going on around us. Okay. So again, here's that image. Diaphragm pushes down, intercostal muscles push up and out. It makes your chest bigger during inspiration. During expiration, that is a passive process. One note is a good note here. There's some term we talk about with breathing that nurses will use, and you'll see this term as using accessory muscles. So it's kind of highlighting our scalenes and our sternocleidomastoid. If you kind of remember the sternocleidomastoid muscle a bit, that big muscle that runs on either side of the neck here. Well, that's a bad drawing, but sternocleidomastoid. So if you see people using like their neck muscles and more abdominal muscles down here to breathe, those would be called accessory muscles. Like, I'm not having time, accessory muscles. If I'm using those to breathe, I'm working hard to breathe. That's working too hard to breathe. Okay. And so using accessory muscles is not a normal pattern of breathing. So if you hear this is a need to know for my test, for your future as a nurse. When you hear using accessory muscles to breathe, they're talking about using your neck muscles, your sternocleidomastoid, using your abdominal muscles to breathe. That is using accessory muscles. We don't normally see visually when we're breathing, we don't see us using those muscles. If I see someone use those muscles, I would say, hey, that patient is using accessory muscles to breathe, and that's not a normal pattern of breathing, and we need to evaluate that further. Okay. So that's what they're talking about with the accessory muscles, if you hear that. Okay. Let's see, secondarily, so keep it going. We're talking about breathing. We're talking about our pulmonary ventilation. So why is this not working? There we go. So again, main muscle responsible for pulmonary ventilation. You guys know this one. Diaphragm, right? So pressure and airflow, again, what we breathe is atmospheric pressure. So running through this again, this picture here, what the body is doing is saying, hey, The lungs operate on a negative pressure system, meaning that they are the pressure inside, intrapulmonary pressure. The pressure inside, okay, should be right. Uh, Lower. Traditionally, it's a negative pressure. It's a lower system. It's a different pressure system than the world around us. It's just different pressure. It's lower typically. But what it's saying is that because our muscle movement dictated by a nervous system pulls our ribs open, making the kind of filling up, pulls them open, the air outside wants to rush in. It rushes in, it fills the lungs up. As soon as those muscles are done contracting, they peak, right? They peak contraction. They can't contract anymore. Air is as big as it is. It starts to fill up. It fills all the way up with air until a certain point. It's full with air. Gas exchange happens in that point, and then our muscles start to relax. And as they start to relax, it increases the pressure in intrapulmonary pressure, increases the pressure inside. And when that pressure gets high, the combination of the muscles relaxing and the pressure increasing pushes air out. And then it just rinses and repeats. Then the cycle flips again, pressure changes between the lungs and the atmosphere around us, and it forces air back in. And then we just rinse and repeat along with the muscle movement. So again, you still have to have your nervous system and your brain intact to breathe without thinking about it. But overall, the airflow, the pressure is what dictates breathing in and out. Okay. And so this video should kind of summarize it.
Air moves in and out of the lungs because of a pressure gradient. When pressure within the lungs drops lower than atmospheric pressure, air flows into the lungs until the two pressures equalize. When pressure within the lungs rises above atmospheric pressure, air flows out of the lungs. Pressure within the lungs depends on the action of the skeletal muscles of the trunk, particularly the diaphragm and the intercostal muscles. Inspiration begins when the intercostal muscles contract, pulling the ribs up and out, while the diaphragm contracts and moves downward. This enlarges the chest cavity in all directions. The parietal pleura, which is attached to the ribs, has a suction-like effect on the visceral pleura, which covers the lungs. As the parietal pleura expands, it pulls the visceral pleura and the lung with it. When the lungs expand, the volume of air in the lungs spreads throughout the enlarging space. This causes the pressure within the bronchi and alveoli, called intrapulmonic pressure, to drop. When intrapulmonic pressure drops lower than atmospheric pressure, air flows down the pressure gradient into the lungs. Whereas inspiration is an active process requiring the use of muscles, normal expiration is a passive process resulting from the recoil of healthy lungs. In expiration, the diaphragm and external intercostal muscles relax, and the thoracic cage springs back to its original size. The thoracic cage compresses the lungs, causing intrapulmonic pressure to rise. When intrapulmonic pressure rises higher than atmospheric pressure, air flows down the pressure gradient and out of the lungs.
So hopefully that was a decent summary. Kind of, again, I think that some of the videos are the best. Okay. So factors affecting airflow. I need to make that point. This is on the page that's right above a life lesson called emphysema about chronic obstructive pulmonary disease, which I will mention here in a sec. But factors that affect airflow, it names three basically. Diameter of the bronchioles. We talked about that with asthma, right? Asthma is inflammation and the bronchioles constrict. So they get smaller diameter, they get constricting down versus bigger. And when we talk about that, that affects it. Pulmonary compliance, it's talking about how elastic the lung is. The lung is supposed to be moving all the time and elastic. It's kind of like the heart where it's always pumping. It's got to be elastic. So if for some reason lung tissue loses elasticity, excuse me, that's diseases like tuberculosis, black lung, or pulmonary fibrosis, diseases that cause scar tissue in the lungs or things like that, makes the lung stiffer, chronic obstructive pulmonary disease, those kind of things, they're going to make the lung compliance go down. Now the lungs can't stretch as well. And the last is called alveolar surface tension. So the alveoli, this is an important one. So I'd say out of all of them, kind of the highlight here is alveolar surface tension. Okay. Here. So alveolar surface tension is something that we got to pay attention to. Alveolar surface tension is saying this word, or this, it's bolded in the book, but it's surfactant. Surfactant. This is a need to know. Surfactant is a need to know. Okay. Surfactant, all right, is something that is pretty important. So surfactant is something that is They describe it as a lipoprotein, a lipid protein mixture. But it's basically just a secretion that our alveoli have that allows to disrupt the molecules of water and other molecules. And so what they call is it holds surface tension. It prevents the alveoli from collapsing because they have all this air and the world around them is kind of trying to force them close. And to keep them open, we have surfactant. It keeps the alveoli surface tension up. Um, Basically keeps water and other molecules from mixing together. And because of that, it allows the alveoli to stay open. If surfactant is damaged, if this secretion is damaged, example, smoking, that the tar and the other things from tobacco mess with this surfactant, they kind of ruin it. Alveoli can collapse, and that could cause lung collapses, or it can just cause general disease and inability for alveoli to do their job. So, out of these kind of factors that affect airflow, that's on that page, alveolar surface tension, the one word that coincides with alveolar surface tension is surfactant. Is this guy surfactant, that this substance that helps keep that alveoli open? That's how I would describe it. So, factors affecting airflow, one big one, surfactant. Um, Substance produced in the lungs that keeps the alveoli open and keeps them from, collapsing. Okay. And so there's another discussion there that we want to get to is emphysema, which is one of the conditions, it's a form of chronic obstructive pulmonary disease, COPD, chronic obstructive pulmonary disease. This is one of them. Emphysema. This is the one the book is highlighting. So this one, there's an image in your book that talks about something called barrel chest. But what emphysema is in a nutshell, it is a chronic obstructive pulmonary condition. Pulmonary means lungs, so COPD, that the alveoli walls get destroyed, causing the alveoli not to be able to recoil. So it's showing you kind of alveoli with emphysema. The walls of the alveoli all meld together and they get destroyed and it kind of clumps up. Sometimes the alveoli collapse, but a lot of times with emphysema, the alveoli actually enlarge. They lose a lot of their dynamics of their little blebs and they become one giant like bleb inside the lung tissue and they get trapped with air because they can't recoil, they can't stretch, they lose the elasticity, is what the emphysema is. And so the alveoli can't stretch anymore and they kind of just stay stuck open. And so where air gets down in them, air is used to kind of moving with the flow of the lung tissue as it gets smaller and kind of big and stretch. And it doesn't happen and air gets trapped. So with emphysema, the key to emphysema is typically cigarettes, but other pollutants. People working in factories can sometimes be a small percentage of cases, but typically it's going to be cigarette smoking, but it can be other inhaled things around a job place are contributing factors to this. So it restricts airflow, causes air trapping, and that air trapping, if you look in the book, shows that picture of a barrel chest. The chest gets filled with air, and so people with emphysema have a hard time. They can breathe in, but they have a hard time exhaling, which should be a passive process. They can't get the air out, so they cough and they have to work really hard to get air out. And so that over time wears their lungs out, wears out their muscles around their chest, and they get tired. And a lot of times emphysema can be a killer. And so a lot of COPD can be a killer. So that read about COPD, that's my explanation. But these are my points for COPD. Alveolar walls get destroyed because the alveoli can't recoil very well, causes air trapping. This is the barrel chest, and it's a part of COPD. Okay. So measurements of ventilation is talked about kind of on the next page. My highlights for this are pretty straightforward overall, but my highlights for this would really just be that some of the terms here. So what they're talking about, measurements of ventilation is talking about how much air we actually breathe in. So one big thing I like to mention to people is that we don't push all air out that we can. Like we don't breathe every bit of air we can, and we don't breathe every bit of air out that we can get. You can see here that our total lung capacity is 6,000 milliliters, a big volume of air. But our vital capacity is the key when I'm trying to highlight. Vital capacity is the amount of air that can be inhaled and exhaled, so inspired and expired with the deepest possible breath. That's vital capacity, okay? And so what that means, vital capacity is saying that we have some air that gets left behind every time we breathe in or out. Why though? We're designed that way. So my point to this is why the leftover air? What would be the purpose? Gas exchange, right? Gas exchange. The whole point of the lungs is to, right, get CO2 out and bring more oxygen back into the red blood cells. we have to be able to still do that in between breaths. There's still like this split second, right, in between, breathing out and the next, right, breathing in between that moment, we still want the exchange of gases to happen, because if we didn't, we'd pass out and be dead a long time ago, because there'd be no gas exchange happening for that. Those split second, those milliseconds, however long is in between breath. And so what vital capacity is saying is this is the actual capacity we can really get out of our lungs, and what's left is residual volume is the name for that. Residual volume is what's kind of left over. That would be here. Residual volume is another definition where residual volume is what's left over, and we need that so gas exchange can keep happening. So those are my two highlights for you: vital capacity, residual volume. Those are definitions, but just so you understand how ventilation works, how the lungs work, is that we do keep some air in there in between breaths, because we have to keep gas exchange going every split second of every day. Otherwise, we're done. We need oxygen every second of every day. So moving further into the book, there's a chart on the next page over that talks about key respiratory terms. And so that is just something we really want to know in general. There's a lot of respiratory terms, but there's, of course, there's, some keys that we want to know, and we want to know these keys. So for example, these on this slide are the ones that I would focus on. I could say there's some bigger ones, I suppose. Like, for example, as a nurse, you should definitely know what apnea is, right? Apnea is temporary cessation of breathing. Okay. This can be like sleep apnea is the most common one, right? I don't know why my highlighter is that color. Sorry, guys. Of course, that's the one you want to know the most, because, well, what does that mean? Well, that means that we are, right, apnea. This is a weird highlighter. Sorry, guys. So apnea is temporary cessation of breathing. We want to know that one, right? Because overall, that's going to be the most important thing we can think of, because we want to know if someone's apneic, that means they're stopping breathing, and whether they're apneic often or at night during their sleeping cycle, which is sleep apnea, it's a big deal. So apnea, another name that comes up sometimes is eupnea. Here in the middle, eupnea is relaxed, quiet breathing. So right now, as you're just sitting here watching this, if you're not breathing too fast or too slow, you're relaxed breathing. That's eupnea. Eupnea is breathing. All the breathing stuff typically ends up being eupnea. So some of kind of all these are need to know. It's hard not to say these aren't need to know, but what's really on your test, I'm not going to test you on every one of these. It's just, I'm not, but I think that these are need to know for nursing. These are common respiratory terms. You're going to get tested over them again in first trimester. I know it's a lot, but it's just worth knowing. Okay. And this chart is good. And this slide, so I try to summarize them very quickly in the slide here. So bradypnea and tachypnea. So Brady, we learn with the heart rate. Brady means slow, right? Tachy is wacky, it's fast. So bradypnea is slow, tachypnea is rapid breathing, just about speed. So a normal respiratory rate, let me say that now. It says it in the book, but you need to know the normals for a lot of stuff. And why don't we start here, right? So the normal respiratory rate for somebody is 12 to 20 excuse me, 12 to 20 BPM, which is not beats per minute, it's breaths per minute. That's the normal respiratory rate for an adult. Now, children, whole other thing. Adult, 12 to 20. So we've talked about normal heart rate. We talked about normal blood pressure. In this case, normal respiratory rate for somebody, how fast or slow it should be, is 12 to 20. So if someone's bradypneic, they could just be 10 breaths per minute. Some of us breathe 10 breaths per minute sometimes when we're really relaxed, but that would be considered bradypneic, slow. Tachypneic would be above 20. So 22, 24 breaths per minute. That's still tacky. That's still considered rapid, even though maybe we just got done working out. The other things, dyspnea is another key one. I'll kind of put a big circle around the big guys. Apnea is a big guy. Dyspnea is another big guy that we want to know for sure. Dyspnea is just another one that kind of just comes up, so dyspnea is a big one, means labored or difficult breathing. So not apnea, not cessation of breathing, but dyspnea is like I'm having difficulty. Like I talked about, if someone's using their accessory muscles, right? That is sometimes called dyspnea because they're working hard to breathe. We shouldn't be working hard to breathe. It should be a very relaxed, natural state. Now, would you say someone that just got done working out is dyspneic? Not really. You'd have to watch them and see. There should be time where someone gets done working out, right? Catch your breath back and it slows back down. If people are struggling to do that, they could be dyspneic. If someone is short of breath or having difficulty breathing from walking 20 feet versus like mountain climbing, well, then that could be dyspnea, right? So it depends on the person and in the situation. But dyspneic just means labored or difficulty. If they're using accessory muscles, they're having difficulty, they're having that. And on the same one that comes up sometimes is this orthopnea down here. And again, I'll kind of go back to circling stuff to give you more of an insight, but it would be orthopnea down. The circling is saying this is a kind of a real big one. Orthopnea is labored breathing that occurs, difficulty breathing. So it's dyspnea, but it's specific when people are laying flat. So a lot of people that have respiratory diseases sleep in chairs and stuff like that, sleep upright because they have a lot of hard time laying flat and they can't feel like they can't breathe. And that's orthopnea. The other ones here is hyperventilation and hypoventilation. Okay. Stay with me here. This one, they get a little confusing because you would think, well, we have bradypnea, right? We have tachypnea. So I understand those, right? Slow breathing, fast breathing. Well, what is hyperventilation, hypoventilation? They're related, but they're also different. So note that hyperventilation is different than tachypnea. Hyperventilation is saying an increased rate of respirations. Yes. So tachypneic, but hyperventilation means they have lower levels of blood CO2. So what hyperventilation is, have you ever seen a movie, right, where someone's freaking out, the kid in the story, I think a good the movie It, some of the newer ones, but someone's freaking out and they're breathing, they're having a panic attack, right? That's hyperventilation. And what's happening is I'm blowing off. So our body still needs CO2. We need a balance of CO2. We're going to learn about why we need CO2. Why not get rid of all CO2? It's a byproduct, right? It's waste from our cells' metabolism, correct? But our body is used to a balance of this. Definitely a lower balance of CO2 compared to O2. But for example, this is good to think about when we talk about acid-base balance later. Hyperventilation, rapid breathing, right? I'm blowing off too much CO2. So my CO2 level is going down and that's out of balance. And we always want to be homeostasis, right? We want to be in balance. So that's not good to have losing CO2. It can cause us to act a little bit weird. And when people give people a brown paper bag when they're hyperventilating, it's because they're going to pass out because their CO2 levels are dropping and everything's getting out of whack. You give them a brown paper bag, if they breathe into that, they're blow off CO2 and they breathe the CO2 right back in. And so they can balance their CO2 levels in their blood. Hypoventilation is reducing the rate of respiration, resulting in blood levels of CO2 climbing. So I'm bradypneic, but it's so slow that now my CO2 levels are affected and they're rising up, which is also bad. We don't want high CO2 levels. That could cause us to pass out or get disoriented, get sleepy. That's hypoventilation. So I'm not going to circle these ones because I can give you full transparency. I'm not really going to ask you test questions on these because these are more advanced, but they're related. These guys are related to tachypnea and bradypnea. Hyperventilation, hypoventilation are going to make more sense when we talk about acid-base balance, and they're going to be something you need to know for the nursing program. You need to know as a nurse. But for now, these are all the big ones. The big three, I would say for me in this test is, do you know the normal, or the big four, know the normal respiratory rate and some of these terms? Big terms: apnea, temporary cessation of breathing; dyspnea, labor to difficulty breathing; orthopnea, labor breathing that occurs when I'm lying flat. Okay. I know it was a lot, but hopefully, you know, everything's a lot, guys. It's all a lot. Find a way to concise this stuff, boil it down to its root. Okay. So a lot of the other stuff that the chapter talks about, it gets in depth to things about the gas exchange process and partial pressures of oxygen and partial pressures of CO2 and all these things. And we're not going to worry about it. There's a life lesson that talks about abdominal thrust, talks about the Heimlich maneuver. I assume most of you know how to do a Heimlich maneuver. That's talked about in CPR. You all have to have CPR for the program. Not going to test you over that, so don't stress it. Not going to test you anything over a process of gas exchange necessarily. just know again that gas exchange itself is that process we want to happen, right? When we are at the alveoli level, at that microscopic alveoli level, we have the blood vessels all running up next to the alveoli, the sacs, all these circle sacs, and we want them easily to get rid of CO2 and retake oxygen. We want that to be easy. So anything that makes that not easy could be a problem. And that's why the correct ratios of oxygen and CO2 does matter for this process to happen correctly. Okay. So kind of the last thing is factors affecting gas exchange. That's the last big thing I'm going to test you over or look at all from this chapter. And that's towards the end, one of the last pages. There's a chart that has some pictures that are helpful that talks about factors affecting gas exchange. Okay. And so they are adequate airway, meaning that my airway is open, meaning that my, let me show you which one, kind of what I'm talking about here. I'm talking about airway right now. So that adequate airway is saying again that my trachea, my anything from my throat back, my larynx and my pharynx, larynx, and trachea is all clear, not obstructed by anything. Adequate airway matters. Again, adequate airway could also be my lungs are stable, they're vital. Again, if I have a respiratory disease or have something blocking my airway, right, then it doesn't matter. I'm not going to have proper gas exchange. If I have conditions like asthma that's constricting and inflaming my bronchioles, chronic lung diseases like emphysema or what's called chronic bronchitis, all these conditions are going to affect my airway in general. That's the whole kind of respiratory system is all about gas exchange. And starting from the top down, if it's blocked or it's not working effectively, it's a problem. Also, I have to have a good respiratory rate, an adequate respiratory rate. If my respiratory rate is real low, like we talked about, that could be bad, right? Like if I take a drug, a narcotic, like an opioid, like a morphine or an oxycodone or something like that, it sometimes suppresses respiratory rate. If it's too low, then my gas exchange is affected. That's a problem. Alveolar surface area, that kind of goes hand in hand. My alveolar have to have that surfactant again, the surfactant stuff, right? A VLR have to have the surfactant. They have to be open as a little ball, and the VLI need to not be collapsed, and they need to be functional. If they're messed up in any way, the VLI, the whole process kind of breaks down. It also mentions a pressure gradient, and on the book, it's got a picture of a mountain. This is just saying again that if I go somewhere that's lower pressure, like high altitudes and mountains with less oxygen, then I'm going to have the less oxygen entering my bloodstream. I'm going to have, when I breathe in, I'm going to be taking less oxygen. And so my body's going to have to compensate by breathing more and sort of stuff like that. The other thing is lung tissue, which kind of goes back to airway in general, and alveolar surface tension. But if the lung tissue itself is not flexible, like the heart, it has to be moving and expanding, contracting. And the lung tissue is not compliant. If it gets stiff because of some disease, then the alveoli can't expand and contract like they want to, and our lungs won't fill with air properly, or in the case of emphysema, we won't get air out effectively. And that's lung tissue needs to be compliant, like flexible, like whatever, however you want to say that. And then the last, and the one you can't always forget about, is blood supply. Blood supply means that, again, in general, if I'm bleeding to death, eventually my breathing is going to suffer because I just don't have enough red blood cells to carry the oxygen and get rid of the CO2. So I got to have enough blood and hemoglobin to have that happen. And if I'm bleeding or for some reason I'm anemic for any other reason, anemia can directly affect breathing. If anemia is really low, it can directly affect it. And so basically just means that if I don't have enough blood, I have fewer blood cells to do this gas exchange process. So all those can affect it. These factors affecting gas exchange, just thinking through these, I can't say that I'm going to test you on every one of them, but I think it's a really good need to know for nursing, because all of these are high level thinking. When you start thinking about patients and like what's going on with them and figuring stuff out with patients, it makes sense when you start putting these together. Like, okay, what's wrong with the patient? Oh, they have COPD, they have a chronic lung disease. Okay, so that means maybe their alveolar surface tension is bad. It means maybe their lung tissue is not compliant. You see? Oh, someone's anemic, means they don't have enough blood. That's why they're having breathing trouble. You see what I'm saying? You can kind of start putting stuff together, but you have to kind of know this foundationally. So that covers everything with chapter 18. I know this is a lot of stuff. I know this unit is a crunch. It's a lot of material, but you can do this. All you can do is do the best you can, guys, right? Do the best you can. That's all you can do. So do the best you can with this. Make sure you look at these videos over the weekend. Email me if you have questions. We'll talk a little bit about it Monday, but we got to keep our schedule. Hang in there, guys. Keep going. You can get this done. So I hope you guys have a great night and God bless.